Hi everyone. Good morning, good afternoon, good evening, depending on your time zone. My name is Godwin Pius Ohemo, and it feels really good to be on your screen today. Today is the 20th of November 2025, and the Global Health Network Nigeria is very delighted to have you with us as we commemorate the World Antimicrobial Resistance Awareness Week. We are gathered here to share ideas together and to engage in very intelligent conversation that borders around how we can protect our present, secure our future, and then look at how we can start taking immediate action to safeguard ourselves from the upsurge of antimicrobial resistant infection. So today, just as a way of housekeeping, this webinar is being recorded and it will be shared on the Global Health Network platform. Due to the number of participants on the call, your cameras and your cameras and microphone are disabled. We will be very grateful if you could use the chat box to let us know your name and the place you are joining us from. You can also take advantage of the chat box to connect and to meet and to greet people as well that you might be familiar with or that you're just meeting for the first time. At the end of each presentation, we are going to have a Q&A. We advise that you use the Q&A box to drop in your question. You can drop your question anonymously, or you can ask your question with your name attached to it. Speakers will do well to attend to the questions either by typing to it or by attending to it when the time for Q&A actually comes. So these are the persons who registered for today's event. Some are Nigerians, some are non-Nigerians, and for the fact that we have non-Nigerians on the call, despite that this is the Global Health Network Nigeria event, it shows that the issue of antimicrobial resistance is not only peculiar to Nigeria, but everybody all over the world have interest in it, and we really want to learn so that we can better safeguard our collective future. We want to say thank you so very much for joining us, and we are glad that you are here with us. So quickly, a run through the agenda for today's meeting. I am going to serve as the chair of today's meeting. My name, once again, is Godwin Pius Ohemo, and I work as the Hub and Media Coordinator for the Global Health Network Nigeria. As soon as we make a start, our colleague, the coordinator of the Global Health Network Nigeria, Dr. Olarewaju Ibigbami, is going to give the opening remark. And then we'll take the first keynote that will be delivered by Professor Kome Otukunefo, a molecular and pathogenic microbiologist from the University of Port Harcourt. Then we'll take another presentation from Dr. Chizaram Onyeagala, an infectious disease physician from the University of Port Harcourt Teaching Hospital. And then we'll take another presentation from Dr. Ugonna Morikwe, a PhD candidate in applied science and technology at North Carolina Agricultural and Technical State University in the United States. Then we'll have the Q&A period, and then we have the closing remark or vote of thanks, which will be given by my colleague Goodness Ode, and then our scribe Chinenye Umba is on the call to take note of the conversation and to prepare a very detailed report of the conversation that has taken place here today. So, ladies and gentlemen, without wasting any bit of our time, I very respectfully want to bring to the fore Dr. Azuka Raphael, who is the steering committee coordinator of the Global Health Network Nigeria, representing the coordinator of the country center, Dr. Ola Ibigbami, to give the opening remark. Dr. Azuka, if you are ready, we are ready. Thank you.
Thank you very much, Mr. Ohemo. Good morning, everybody. Good morning, good afternoon, good evening, depending on where you are streaming in from. On behalf of the coordinator of the Global Health Network Nigeria Country Center, Dr. Ola Ibigbami, I want to welcome all of us to the 2025 World Antimicrobial Awareness Week, which is ably captioned "Act Now, Protect Our Present, Secure Our Future, Spotlight on Nigeria." I'm sure we're going to have a very interesting session this morning with our panelists. And once again, I say welcome, everyone. Thank you very much.
All right. Thank you so very much, Dr. Azuka Raphael, for that. Ladies and gentlemen, if you are just joining us, this is the World AMR Awareness Week put together by the Global Health Network Nigeria. Today we are gathered to learn, to unlearn, and to relearn. And without wasting any bit of our time, I very respectfully would like to introduce to us our first speaker for today, who is going to make her presentation on the topic that you can see on your screen, Global Lessons for Nigeria, what we can learn from AMR success story. This will be presented by Professor Kome Otukunefo. Professor Kome Otukunefo is a molecular and pathogenic microbiologist from the University of Port Harcourt. Professor Kome, if you are ready, we are ready. I'll stop sharing my screen and give you the lead to share yours, or if you want me to share for you, I can equally do that for you from my end.
Okay, thank you, Hemo. Please share for me.
Okay, all right.
Good morning, everybody. Welcome again to this talk where we celebrate the 2025 World Antimicrobial Awareness Week. So today, like you've been informed, I'm going to walk you through various success stories globally and what we can learn as a country. So this talk is going to handle the couple of topics that you can see outlined. Next slide, that you can see outlined. And when we're thinking about antimicrobial resistance, next slide, refers to the ability of organisms to withstand the action of antimicrobial agents. What this means is that we have antibiotics, we have organisms that are not affected by antibiotics. And it has been such a scenario that, next slide, over the years, as soon as antimicrobial agents were introduced, what we had was the introduction of resistance, the development of resistance. And this, looking at the next slide, this is not just in human beings. It runs across the different spheres of life. So you see it in humans, you see it in animals. In animals, in addition to treatment, prophylaxis, and growth, you also have it as growth promoters. And that we can see is key. So when we're thinking about this, it means that we cannot address antimicrobial resistance from one angle. Next slide shows that it has to be addressed from a One Health approach, where every single facet that is involved has to be taken care of. What this means is that over the years, we have several key intervention strategies that have been developed, as we see on the next slide. So these key intervention strategies, like we say, they run across all the different facets. So it's not just for animals or humans, it's across everything. So we have various intervention types, and you see the WHO Global Action Plan. You're looking at One Health approach, like I mentioned, and then collaborations must take place. And then we have surveillance systems, policy regulations, control, and then one very important thing is infection prevention and control. That is key because in the absence of infections, there is no need for antimicrobial agents, and then hopefully there will be no development of antimicrobial resistance. So what does this look like? Remember I said there's a One Health approach. Currently, we're talking about a quadruped situation where different organizations are working together. So the next slide illustrates what the WHO has done is the WHO Global Action Plan. And it has a couple of objectives. These range from awareness and understanding of resistance. You're looking at surveillance, reducing incidence of infection, optimizing antimicrobial agents, and you're looking at investment. Investment is key because without all of this, the different objectives cannot take place. The Food and Agriculture Organization has a similar plan, and you can see there is a similar concept running through everything, where there's awareness to strengthening of surveillance and research, and then there's good practice that has to come into play. Here, there's promoting responsible use of antimicrobials. This also cuts across, and then there's resources. And then we have the World Organization for Animal Health. Like I said, the strategies cut across different areas, but they are similar just because it shows what is happening in one area affects the other areas. So when we think about all these different interventions, the question is that how exactly does this look? when we're looking at specific examples of these interventions, because we have the big names, but then when we come to the nitty-gritty, what interventions have been used currently? And then you're looking at conducting training sessions. This runs across all areas. So training sessions in the hospital, for farmers, for the environment. And they are looking at hand hygiene programs. Hand hygiene are said to be the main thing to prevent infection. And then antimicrobial prescriptions. I don't know about other countries, but right now in Nigeria, we have a major issue with antimicrobial prescriptions. What this means is that we don't necessarily need a prescription to buy an antibiotic. You can just walk into most pharmacies and pick up an antibiotic, any antibiotic, and this is not okay. Then surveillance systems need to be integrated. So the information we're getting by WHO has to be integrated by the information, has to be integrated with the information from World Organization for Animal Health. And what are the possible outcomes this is looking at? So we're looking at interventions and we're saying, okay, these interventions, what do we want to see? And then we're looking at better stewardship. People prescribing antibiotics being prescribed when necessary, not for things like a common cold, which is probably viral and does not need antibiotics. We're looking at improved infection prevention and control, like I said, key. Overall, we're thinking about a reduction in antibiotic consumption. And all of this will only be possible if we have the necessary surveillance systems in place, telling us what is happening, and then we can monitor. The final thing we need is reduced resistance rates. So when we're looking at all of this, there's several reports that have been made globally. One of the more recent reports was by O'Neill in 2025. This study compared antimicrobial use, looking at the national NAPs for various countries. So AMRO NAPs, National Action Plans, have been developed by a number of countries. It's a WHO initiative. And so what they did was to compare antibiotic use based on those that have NAPs, those that have low ones or high ones. And it was seen that countries without NAPs had, following the 2019 pandemic, had higher usage of antibiotics, with the least usage being observed in countries with high scoring NAPs. This data was further validated by another 2025 Lancet paper. This paper looked at variation in defined daily doses. So you're looking at defined daily doses per 1,000 inhabitants daily from a number of countries, and it's comparing variations between 2020 and 2021. And if you look at the lower half of that graph, what you see is that we have the red countries being the high income countries. So it compares based on income, high income, low income, and middle income, with low income being blue. So you can see for the high income countries, majority of them had a reduction in their daily doses per 1,000 inhabitants. So this was the data in humans. Going on then to look at the data in animals. So this was the World Organization for Animal Health has a really good data series. It's on their website and is accessible to everybody. This shows for the far left on the top corner, you can see the general global data where there seems to be a reduction in usage. This reduction in usage, however, is not uniform. We can see for the far up right, we have Asia, where you have a higher level of usage, Africa, middle, and then you have Europe that is low. I must point out that all this information has to be interpreted based on how many people submitted data and all of that. So there are biases that must be considered. Looking then at how this has varied over the years with respect to continents. So these 4 graphs show 2018, 2019, 2021, and 2022 is looking at usage as it differed over that time period. I want to highlight the second to the last one, which was for Europe, that has reduced greatly. And for Europe, we're looking at specific countries. I put out the data for 2 specific countries, Sweden and Italy. Sweden is on the left and Italy is on the right. For Sweden, if you just look at it without taking into companies as the value, you can see, you say, oh, there's no much difference. Why for Italy, there's a marked difference over the years. But the main thing is that if you look at the shared numbers for Sweden, Sweden has only 7 milligram per kg usage. And so it has remained stable over the years. While for Italy, it came from 200 and it dropped right up to like 100. So that was a major drop. There's a reason I chose Sweden, because when we look at our AMRO success stories, the first country we're going to look at is Sweden. Sweden has a major AMRO success story. What has Sweden done that can be emulated? First, you're looking at, there's a total ban on antibiotic growth promoters. That is major in the animal industry. So Sweden information is for animal use. And then there's a restriction on use of key human antibiotics. And then they've reduced their penicillin-resistant Staphylococcus aureus from 10% in 1985 to 1% now. The restriction of key human antibiotics, we're talking about glycopeptides, carbapenems, these cannot be used anymore. And the ban was done in 1986. So that's how far back Sweden started to work on this. What was the process that Sweden went through to accomplish this? You're looking at active infection control and disease eradication. They were searching for the diseases. They were preventing the entry of other animals into their country. You're looking at zero tolerance of key contaminants by key pathogens. This zero tolerance, it was quite interesting because there are some cases where if any organism was seen there, the whole animals were called. That is what they did for zero tolerance. And then we're looking at established key legislation. So when we think about key legislation, the concept was very innovative because you have legislation that was looking at control of animal diseases. You have legislation that was looking at you cannot use specific antibiotics without a prescription in animals. That's why it was even amazing. And then control of bacteria with specific resistance, the data generated and disseminated. This started since the 1950s. So the public was informed about all of this that was happening, and there was ongoing surveillance all through. This success story has been repeated in a number of other countries. We have Germany. We're looking at the data from 2011 to 2018. There's a 57% reduction in antimicrobial use in the veterinary sector. And the next slide also illustrates that it differs based on what the antibiotics was, but there is a reduction. Japan too has a similar story. Japan had a process of compiling an antimicrobial stewardship manual, surveillance and monitoring, and there was public awareness and campaigns, just to let everybody know what was happening. And for Japan, what the outcome looked like for that was a reduction in the defined daily doses per 1,000 inhabitants, that's the DIDs. Over the years, if we look at the next slide again, over the years, you can see a reduction from 2013 to 2020. Some antibiotics, I must say, remain the same. But for the key ones, beta-lactams, there was a reduction. For macrolides, there was a reduction. And even for the quinolone, there was a reduction. So that's the success of Japan. What this indicates, looking at specific resistance rates, in specific organisms, you see a 15% reduction, 25-20, and that is amazing. So we've looked at several countries, but none of these, however, is countries that we say developing countries or least lower middle income countries. And so we look at the success story for India. India looked at antimicrobial stewardship over the years. I was checked the number of key tertiary hospitals to see how that impacted. I'm sure we'll have access to this later on. You can see that there was generally a reduction in usage, in prescriptions, in antibiotic exposure. So all of these, quite a number of these were in individual studies, not apart from the World Organization for Animal Health. In humans, we have another important thing we can look at. That's the Global Antimicrobial Resistance and Use Surveillance System. This is GLASS. It's a WHO initiative. It's been available since 2015. And what it does is that it provides a standardized approach. This is important for comparison because when everybody is using the same method, then we can properly compare what is happening from country to country. And it's also involved in capacity building. So if we look at the first slide, after the GLASS slide, what we see is that there's a number of countries that are enrolled. There's GLASS has the ability for you to enroll, but not start providing data, and those that are enrolled and are providing data. And unlike the first 2025 study where Nigeria had no data, we can see here that Nigeria is enrolled, and that is a good thing. We are not yet providing data for all aspects. This was for antimicrobial use, but we are enrolled. And then the GLASS website is available to all. It gives you the ability to compare what is happening with countries. And so looking at the evolution in antimicrobial use in a number of countries, we can see that Sweden, again, remember our success story? Sweden has a pretty steady use that is quite low, followed by United Kingdom and Great Britain. We have some countries, it shows you at what point that the countries join, and then we have Iran had an increase and then a reduction. I must always point out, this data is subject to what has been submitted, and so there are biases that must be taken into consideration. Looking overall at antimicrobial resistance, so we're looking at antimicrobial use previously, but now looking at antimicrobial resistance, this is also a snapshot of countries that are reporting bacteriologically confirmed infections. So we can see that this has increased over the years. And also the number that are enrolled has increased. The number that are reporting data has also increased. And the same thing for antimicrobial susceptibility of those bacteriologically confirmed infections. There has also been an increase over the years. And the next snapshot we see is looking specifically at bloodstream infection. This is a snapshot of countries that are providing reports for bloodstream infections. Nigeria, we can see, is there. So the color coding goes by the number of bloodstream bacteriologically confirmed infections with antimicrobial susceptibility in the bloodstream per 1 million population. Nigeria has started, but our number per 1 million population is not very high yet. And from this data, I was able to show for 2020 how it has evolved. So looking at Nigeria there, Nigeria has a 0.7, that's the total number of bacteriologically confirmed infections per million. That is pretty low compared to Norway, that has a 1,073 per million of the population. And this 0.7 by 2023 was 0.8, and by 2023 it was 1.3. There is an increase. However, it is low. So we see 2022 on the next slide and 2023 on the next slide, from 0.7 to 1.3. There is an increase, however, it is low. I highlighted those numbers. So when we come to appreciate the percent at the far right end, we can see percent of bacteriologically confirmed infections with antimicrobial susceptibility. You're looking at 75%. But remember that 75% is only from a few isolates submitted. And then this website can also give you country comparisons for different organisms per year. So what I did, I created this table from the data within that website. And we can see Sweden. Sweden, and I chose two countries, Sweden and Argentina, just to show different ends. So Sweden has percentage resistance that seems to have increased from 1.9 to 2.1 to pretty low. But you can see the total number of isolates that were submitted from 10,848 to 21,000. While for Argentina, there is a reduction and there's an increase in total number of isolates. So also highlighting just how good Sweden has been. So what does WHO recommend? With respect to interventions that are necessary for the health system to combat AMRO, there are 6 main interventions WHO recommend, and these are key for resource-limited settings. You're looking at leadership training, development of guidance, feedback, accountability, and responsibility. Basically, you're looking at multi-sectoral and multifaceted. And then we're thinking, what is the current situation now in Nigeria? Currently, Nigeria, like we saw, has started something. We're on our second National Action Program. This one is running from 2024 to 2028. We have 2 national reference laboratories selected, 10 laboratories engaged in national antimicrobial in the GLASS system, and then we have SOPs that have been generated. These SOPs were key because it was difficult to compare data from different labs. If everybody is doing the same thing, like I said, it can be compared. So 2 national reference laboratories, 10 laboratories, it looks so small, but that is a start. So what can Nigeria take home? What's our take-home lessons from everything that we've seen so far? I'm sure as you listen, you had an idea of this can be a take-home lesson, this can be a take-home lesson. We need political will. The political will is crucial because without that, nothing is going to be driven. And improved funding. You're looking at communications, collaborations between the different sectors, and the current programs have to be expanded. We have so many states. One thing I would add is if it's possible to do state national action plan. So rather than everything starting at the national level, we can start at the state to monitor. It's so key. So Nigeria we've had a start. We can do better. What I would say is that it's necessary for increased momentum. This is a pivotal time for Nigeria to have an increased momentum. So we have to have an increased momentum now. Nigeria has to act now to save our future. It is key that Nigeria increases its momentum in what we're doing to act now and save our future. Thank you so much for listening.
Wow, that was stellar. That was stellar. Thank you so very much, Professor Kome Otukunefo, for that wonderful presentation that you just gave. Was blown away by the way you articulated your point and how passionate you are about the subject matter of antimicrobial resistance. Ladies and gentlemen, if you are just joining us, this is the World Antimicrobial Awareness Week, organized by the Global Health Network Nigeria. We are very glad that you could make it. Thank you so very much for joining us. Please kindly drop your question if you have any in the Q&A box for Professor Kome. She will attend to the questions herself, either by typing or later when we have the Q&A session. Without wasting any bit of our time, we are going to jump in straight to the next speaker that we have for today, and that is Dr. Ugonna Morikwe. All right, ladies and gentlemen, it's time for us to take our second presentation for today. And on this, we are going to be looking at harnessing artificial intelligence for antimicrobial resistance surveillance in Nigeria. And this presentation is going to be given by Dr. Ugonna C. Morikwe. She's a PhD candidate in applied science and technology at North Carolina Agricultural and Technical State University in the United States.
Okay, good morning, everyone. Thank you, Hemu, for the introduction. I'm excited to be here today, and I appreciate what the Global Health Network is doing, using their platform to bring together researchers, practitioners, and also communities to share knowledge, build capacity, and accelerate solutions that improve health outcomes worldwide. So thank you so very much. Thank you also to Professor Kome for your insightful presentation. So my goal today is to show how AI can strengthen antimicrobial resistance in Nigeria and also inform actionable public health strategies. Now, to answer this, we're going to look at current gaps, emerging scientific opportunities, and a practical roadmap tailored for Nigeria. Gladly, we saw some introductions on the burdens of antimicrobial resistance in the last few days for people that may have joined the section. So here we see that antimicrobial resistance causes about 1.27 million deaths annually, and the highest burden is in sub-Saharan Africa. And we have, hold on, let me close this. Okay, so Well, the reason for that, just like Professor Comey said, is that back in Nigeria, people get antibiotics, over the counter. So we have high antimicrobial consumption in Nigeria. Now, it is important to note that there is a steady increase of antimicrobial resistant levels in Nigeria, and despite the burden, our surveillance system remains fragmented. Now, this means that we miss early warning signs that will occur long before cases present themselves in the hospitals. So the good news, however, is that AI is positioned to fill these gaps. So with AI, we can be able to dictate patterns across incomplete or scattered data. So your data must not be perfect. Now, why is AI important? So AI's value in antimicrobial resistance surveillance is practical, and it has been proven. So studies have shown that with machine learning, we can predict resistance using genomic and epidemiological data. We can also use natural language processing to extract insights, even from doctors' reports, doctors' notes, handwritten notes, typed. We can also use computer vision to automate plate reading and microscopy. So for example, so if you look at these references that I have here, this third one, in the study that they did, they used machine learning to predict capsaicin resistant Klebsiella using routine clinical and microbiology data. Now, when people hear about AI, they feel a bit anxious. But it's good news, and it's important for us to know that AI is not here to replace us. It is here to amplify our capabilities. So it's here to learn from our data. We're going to be feeding our data to AI. It learns from it, dictates patterns, predict future trends, and also guide us and also guide response strategies for us. So for AI to be effective, we must have integrated data, right? So in the previous slide that I showed, you could see how disintegrated the data was. And here, you see this, I use this dotted black lines to show that this data has to be integrated. And so we need this integrated data set from the clinic, environmental data sets, genomic data sets. We need this data even from research lab, right? So these data all have to be unified. So unified and integrated to enable us build early warning systems. So these early warning systems to be able to provide stronger NCDC reports, and that will be better aligned with GLASS indicators. So GLASS is the Global Antimicrobial Resistance and Use Surveillance Systems. So when we look at all these tools and how they are used, it gives concern. Okay, can I afford these tools? It's also good to know that most of these tools are open source, right? So they're open source and free. Most of these tools that are used for integration, so anyone can, source for them and use them towards AI, antimicrobial resistance surveillance. So now here in this, this is GLASS 2025, and here I show. Sorry, here this is this was gotten from the Annex 4 from this GLASS 2025 article. So here we see that this is like scores for availability and completeness of national antimicrobial surveillance. And when you look at these are mostly African countries on this page, and you can see like we have lots of red. So the red boxes shows no data. Let's zoom in on Nigeria because that's our interest. So I zoomed in on Nigeria and blew up the data. So you can see that we will have national coverage of GLASS. So we'll have national EMR surveillance system. Sure, we do have that. National health infrastructure, total health facilities. There's information on that, but there's no information on inpatient admissions and days of care per calendar. There's no information on outpatients, both nationally, right, and also on the facilities that should report to GLASS. the same thing too with the AST infection type. They're having complete data on bloodstream and no data on the other, like just gastrointestinal, urinary tract, and all of those, important factors that should help us. This is like surveillance to help us keep track on antimicrobial resistance surveillance in Nigeria. So the more what can we learn from this data? This is to show us that there is sparse data, would lack data, right, on antimicrobial resistance. And if we lack this data, if we don't have this data, integrating them would be difficult. You need to have this data to be able to work with AI. So it is important that we harmonize, we do that we get this data, harmonize them, and so we're able to improve Nigerians' glass submissions and make nationwide surveillance more representative. Well, so for example, when we lack in the lack of data, how can this be filled? This can be filled by, clinics, research labs, and then this can be drawn, for example, for what I do in my lab, what I do in our lab. My research background centers on environmental antimicrobial resistance on the built environment, specifically sugar metagenomic sequencing of wastewater and home surfaces. Now, this approach, what I do is that what it does is it dictates resistant trends. This is like long before these cases start showing up in the hospitals, right? So it is important that we actually survey our environment. And what it does is that it offers a potential early warning role. So Nigeria can actually benefit from incorporating a study like this. So giving this environmental dimension into national surveillance. However, I would not ignore that collecting samples and running some of this data, so like we can for example, in research labs or academic labs in Nigerian universities can collect samples, design research and collect samples and send them out for them to be run. However, there's now like a bottleneck. What's the bottleneck? We have like co-pilot tools. The bottleneck is post data processing. However, that is also where AI comes in. AI can be used to actually make these processes, very, very easier. But the most important thing is that with this information here, we'll be able to link environmental antimicrobial resistance signals to community antibiotic use and risk patterns. So, like I showed in the previous slide, that one of the bottlenecks that we have in Nigeria is bioinformatics capacity, human capacity, right? So many labs collect data, but then they struggle with processing it, they struggle with analyzing it and interpretation and interpreting it. So, but these AI tools, the co-pilot AI tools, can actually be used to help debug, analyze, and standardize this outputs. For example, you could use AI copilots to write your scripts for R, Python, whatever you want to use to analyze the large data sets that would be getting. So, and what it does is that with these AI copilot tools, it helps strengthen workforce by enabling younger analysts to build competency very quickly. For something that could maybe have taken you a month to learn, with AI copilot tools, you could do that in maybe a day or a week, depending on how dedicated and committed you are. So on this slide, I show an example of the kind of data that we could get when we start antimicrobial surveillance, right? Especially in the environment. So this example, it's from this okay, so I have the references here. So here we see published wastewater metagenomic studies, and when this data is compared, right, to the data from hospitals, you could see that some of these antimicrobial, the complexes that we see in this community data are actually antimicrobial resistant that appear even long before they will be seen in the hospitals. So in essence, data integration is important. We'll get this data from the environment. We also collect data from the clinics, and all of this data will be integrated. Therefore, we'll use it to train AI and also help us to predict future emerging threats of antimicrobial resistance. So here, with AI-driven surveillance, we can generate genomic data sets needed for machine learning. It can help us extract data for predictive antimicrobial resistance modeling. It can't be overemphasized, right? That would use it to integrate both environmental data and clinical data and also laboratory data. So now, looking at this, what is the vision? What is the vision? What is the vision for Nigeria? So a national system where we have hospitals, environmental science, genomic labs, all contribute the data, right? And we'll have a harmonized data sets. Then we'll feed this data into an AI model that will now analyze them in real time. So with this, we'll be able to dictate hotspots and forecast resistance, right? So, and with that, we'll now have dashboard or systems that cannot be fed into NCDC and also the state antimicrobial resistant technical working groups. And also will now use to inform policy. And therefore we'll also be ready like for stewardship programs, right? And then we also, all of this aligns with the Nigeria's National Action Plan for Antimicrobial Resistance and also enhances GLASS reporting. And so when we need to like provide information, provide data on the global antimicrobial resistance and use surveillance in Nigeria, we would have all those information because we've been able to gather this data from all the hotspots or labs or sites that are required. So here, I am trying to show how we can use this, the workflow, right? So this is like a use case. So I try to use what I do as a use case scenario, as a use case on how we can provide early warning sign of AMR in the community. So this can be done, for example, wastewater, like I can't overemphasize it, wastewater, and also household surfaces. Now, there's lots of data on clinic, like hospital acquired infections, right? Nosocomial infections. But then we'll have limited data on limited antimicrobial resistant data in households. And also we could have lots of data also in wastewater. But then this data is lacking in so if you're trying to do maybe a review on antimicrobial resistant data information on Nigeria, you find out that there's sparse data. So we really do need, to do some of this environmental analysis, also analysis in household. So what this does, what I show here is a workflow where I have wastewater or household surfaces that can help dictate antimicrobial resistant genes, the levels of antimicrobial resistant genes, and then the machine learning where you can, model it to identify potential hotspots, and then the signals can be validated with clinical antibiograms, like one of the studies that I mentioned where they used clinical antibiograms to actually confirm the presence of Klebsiella pneumoniae. And this actually also saved time. So what also, after that, what you can do next is this can create alerts, that can be shared with these technical working groups and build stewardships, like I had said earlier. So when all this is confirmed, this is now this cannot be provided into the antimicrobial resistance report and build stewardship program that can be used to adjust antibiotic guidance proactively. So this workflow here transforms surveillance from reactive to predictive. So that's the importance of what we see here. And this is like an illustration, like a diagrammatic illustration of the of what we had in the previous slide, showing us the workflow of how we could use data from the environment, data from labs, data from the clinics to actually, have this is like a genomic pipeline for antimicrobial resistance using genomic sequencing and also AI. Now, despite the bottleneck that we know very much often, and because like I said, before we start talking about using AI, we need to like generate this data, right? So, but then how can we begin? Looking at the big picture, we do not need to necessarily scale nationally immediately if I have to recommend. So the realistic approach would be to start with 2 to 3 states, right? So we could say Abuja, Port Harcourt, Lagos. So 2 to 3 states with strong laboratory capacity and existing surveillance networks, and then integrate this data across the states, those 3 pilot states first. And then, so what this is going to do is that with the integration of this clinical and environmental data supported by AI, we'll be able to see how we'll be able to demonstrate feasibility, quickly, right? Instead of going on a national scale. And so with that, we'll see how this like incremental models, with these models, we'll see how we can reduce costs, minimize risk, and also accelerate the adoption, across the country. So the point I'm trying to say here is that we can, like Nigeria has the capacity and expertise, and we also have the partnership, like to leapfrog, right, by combining environmental, clinical, and genomic surveillance into next generation antimicrobial resistance surveillance data. So the truth is that the tools exist and they are cost effective. We can lay our hands on tools that are cost effective, and then from there we can now escalate into national capacity. So like I said, the tools exist, the science exists, and the opportunity is now for us to take charge and build data and build surveillance data that would help us predict emerging threats of antimicrobial resistance. And as the team says, act now, protect our present, secure our future. It is important that we join the bandwagon of artificial intelligence, use all the resources that we can to make sure that we are able to, provide the data that we're required to stay on the forefront to combat the global crisis of antimicrobial resistance. Okay, so thank you. I want to say thank you to Global Health Network again, to NSF Premier, where I work, and then A&T, and also to my collaborators and mentors. And I'll take questions.
Oh, that was wonderful, Stella, and straight to the point. Thank you so very much, Dr. Ugonna. We really appreciate your time and the effort you've put in place to prepare this lecture and for your availability to make the presentation. Thank you so very much. We are very grateful. Ladies and gentlemen, if you are just joining us, this is the Global AMR Awareness Week webinar put together by the Global Health Network Nigeria. We've had two insightful presentations from 2 excellent speakers, Professor Kome and Dr. Ugonna. And next on the line is a very respected professional that I respect a lot, and he is going to make his own presentation. Dr. Ugonna, I know you are very anxious to take questions, and we would like to encourage our audience to please use the Q&A box. Drop your question for Dr. Ugonna or for Professor Kome. As soon as the 3 speakers are done presenting, we are going to take the questions, serve them the questions, or better still, if they are pressed for time, they can as well just type their response to the question in the Q&A box. Apart from that, I want to say thank you so much to you, Dr. Ugonna, for your presence and for making our time to make this presentation. Ladies and gentlemen, it's time for us to take our next presentation, and the next presentation is going to be given by Dr. Chizaram. Dr. Chizaram is an infectious disease physician at the University of Port Harcourt Teaching Hospital. He is going to be speaking to us on the topic antimicrobial resistance in Nigeria, current realities, challenges, and the way forward.
Well, thank you so much, Godwin. Good morning, good afternoon, and good evening to the participants and colleagues who have joined this webinar, depending on the part of the world where you are joining from. And let me sincerely appreciate the Global Health Nigeria Network Nigeria for inviting me to make this very important presentation as part of the World AMR Awareness Week for 2025. I'll be speaking on AMR in Nigeria, current realities, challenges, and the way forward. And let me also appreciate previous speakers who have done very well on talking about AMR from the global perspective and other components of AMR, including data and AI use. Okay, so my presentation will basically be on these three objectives. What are the current situation of AMR in Nigeria? What are the challenges associated with the AMR response in Nigeria and the way forward? So I would like to begin with a statement that was made by Alexander Fleming, who is the inventor of penicillin, in a small laboratory in London, who I would like to quote in verbatim, who said, "The time may come when penicillin can be bought by anyone in the shops. Then there is a danger that the ignorant man may easily underdose himself and by exposing his microbes to a non-lethal quantities of the drug make them resistant." Now, this statement was made in December 11th, 1945, about 2 years after the discovery of penicillin. So that will bring us to know how long and how far we've come with AMR. So just a simple definition of what AMR is. So AMR occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to medicines, making infections harder to treat and increasing the risk of spread, illness, and death. Now, many people will be asking, whenever we're talking about AMR, why is it that we are specifically and almost interested in the antibiotic component of the whole line of antimicrobials? That's because AMR itself is a natural phenomenon which is expected to happen as a gradual process. But when other factors make the resistance level occur at an unprecedented rate, that makes the antimicrobial resistance worrisome, a global public health threat, and a silent pandemic. And most of these exponential, expedited antimicrobial resistance have been found to particularly occur within the bacterial and the fungal pathogens. And that's why AMR is specifically on antibiotic resistance and now antifungal resistance. So if we look at this slide, you can see that drug-resistant infections threaten us all across the world, but not equally. So if you look at the map we are seeing, like the world map, you see the sub-Saharan Africa being predominantly affected by drug-resistant infections, as much as other parts of low-resource countries in Europe and the South Americas. But my spotlight for this presentation is in Nigeria, and we can clearly see that Nigeria falls into the sub-Saharan Africa, where we have increased antimicrobial resistance. So we cannot really talk about AMR today without talking about the 2022 Lancet study. That was a GBD study that was done in 2019, that was published in 2022, but from findings that were found in 2019, which showed that there's about 1.27 million deaths from AMR, and that 4.95 million deaths were attributable to antimicrobial resistance. So we could see that the death rate itself is becoming a problem. So the next 4 or 5 slides I'll be sharing will be giving us an information to what we are seeing with AMR. So if you look at, again, at this slide, you could see about 700 deaths each year from AMR, and it's projected that by the year 2050, there may be at least 10 million deaths from AMR, and it will cost the world $3.4 trillion to be able to deal with this global public health threats. So what does it mean for Nigeria? So direct deaths for Nigeria is put at more than 64,000, and then associated deaths from AMR is put at more than 263,000. That's quite a number. And Nigeria ranks 19th among 204 countries that have AMR-resistant deaths. We believe that these numbers are grossly underrepresented because we don't have much data that we are contributing at the time these studies were. So we've talked about this. This is quite a number, and we should be worried. So how does antimicrobial resistance spread? It's actually a complex web. And that's why when we talk about antimicrobial resistance, we particularly talk about other factors, such as other man-made activities that can lead to the spread of this resistance. And one of it is the use of antibiotics in animal husbandry. And that's why you could see the spread from the animals, and the man consumes some of this, spread into our guts, and from there we get to the hospital to seek, hospital care, and then there's a hospital spread, and then all of us spread it out to the community. So it's a cycle, and that cycle starts from the use, not even just using it in human health, but the use in animal health, and then for the antifungals, the use in environmental health, the use in plant health. And that's why we'll soon be talking about the multi-sectoral response to AMR, because it's not just the human health component that is driving this resistance. So we could see the selective pressure, imprudent use. We use this just to fatten our animals, to make them grow fast, to make them so that we can increase our earnings or make more money. And then from there, it gets to human, because there is the interface between animal and human is narrow. And then from there, we have increased human mobility. And these are all the other consequences of the AMR: mortality, increased healthcare costs, increased carriage and dissemination, and then, of course, resistance. Somebody can even ask me, how does some of these things happen? Because I say that most of the imprudent use of antimicrobials in animals does not happen in Nigeria. Nigeria does not even consume or prepare, do a lot of animal husbandry compared to what you have in other parts of the world. But because of travel, international travel, these resistant genes they don't have any border. They can travel from Europe to America, from America to Africa, and that's a significant chunk of why we have some of this resistance playing out in Nigeria. So most times, when we talk about antimicrobial resistance and drivers and causes of antibiotic resistance, we often always focus on overprescription by doctors. That's very simplistic. A doctor just sees a patient, it's supposed to be a flu, maybe an acute epiglottitis, which is caused by viruses, and the doctor prescribes, let's say, penicillin-based antibiotic. That's just one of it. There are so many other things. We don't even have very good hygiene in our country. If you go to most of the hospitals, you may not see a clean and running water. Of course, our sewages are not as perfect as it should be, particularly in the resource and in the rural areas. Of course, we've talked about the spread of infections in the hospitals. The hospitals are overburdened. You have more patients than you can provide care. So the cohorting, the separation, the nursing staff, the healthcare workers are not enough. So most times you see one nurse, one doctor caring for 300 patients. How does that doctor maintain, the 5 moments of hand hygiene? How does that doctor or the nurse wash his hand after each patient? Now you have infrastructure. There may not even be personal protective equipment as simple as, hand gloves to attend to all of these patients. But the one that breaks my heart the most, which I also want to talk about, is limited diagnostics. So when Prof was talking about, you could hear him talk about in our AMR surveillance network, what we have is just about 10 to 12 laboratories as at the time we are developing our NAP 2.0, catering for 230 million Nigerians. So why would the doctors not do overprescription? There are no diagnostics. A doctor has a patient he wants to see, the lab is not there, or the lab is not as optimal as it's supposed to be. Now the doctors have to rely on prescription, probably not even with the guidelines And all of this drive resistance. Of course, we've talked about the zoonotic component, particularly for the animal and antibiotics, but for the antifungals, more of plants and the environment. So all of this put together just make antibiotic resistance occur at an accelerated rate, causing a silent pandemic. People are dying from antimicrobial resistance related deaths, and most of the numbers are not even being contributed to the surveillance network. So we just said to put down some of the things we've talked about, and not limited to that, other factors that could also accelerate AMR in Nigeria include substandard quality drugs. We know that recently NAFDAC have been coning down on most of these markets. In Onitsha, in Aba, NAFDAC have been burning down a lot of counterfeits, a lot of substandard, a lot of fake drugs. So it's not just even about appropriate diagnosis from the laboratory, or even about behavioral inconsistencies by the prescribing physician. Even the drug that you're taking, if the regulatory authorities and if the country and the political will is not there to make sure that this medication, which you are supposed to take, it's original, it's standard, you may end up having a non-lethal dose of the antibiotics, and that will drive resistance. So that's also another problem. And that's not to take away the fact that we have a huge burden of infectious disease in our country and all the other ones, which I'll be talking about shortly. Next slide. So you cannot talk about antimicrobial resistance without looking at it from the lens of the One Health. And that's because many of the things that happen, many of the things that drive the antimicrobial resistance and the antibiotic resistance, particularly, is coming from the animal health. And there is a close interface between human and the animal health. So you cannot address it alone. The human health professionals cannot address antimicrobial resistance alone. You must get to the animal health. They must do the right thing. They must vaccinate those animals. They must do responsible antibiotic use in the animal health. Same with the environmental health. Same with antifungals that we're using for plant health, for aspergillus, and so many other things. So you must look at antimicrobial resistance from a One Health perspective, and that will make you to look at it from what? Providing a multi-sectoral approach. The World Organization of Animal Health, the World Health Organization, the United Nations Environmental Program, and even the Food and Drug and the plant health component of it also has to be part of it. So when we talk of antimicrobial resistance, how do we even diagnose? How do we even detect that there's resistance? So there are two ways, and the previous speakers have talked about it. Either you are doing a phenotypic testing, right, which you can do using a micro dilution, Dix diffusion, gradient agar dilution, and many others, or you are doing a genomic sequencing. Unfortunately, in our country, this diagnosis seem to be a challenge. Now, there's been a lot of, like Prof has said before, there has not been standardization in the reporting of some of these investigations, but now we are beginning to standardize our reporting and our testing. And one of the things you can use is the Clinical and Laboratory Standard Institute. That's what the US uses. With that, you can do your phenotypic antimicrobial susceptibility testing and reporting. And of course, when it comes to the whole genome sequencing, it's a bit more expensive. We have to invest in these things. In Nigeria, as at the NAP 2.0, it is only the University and College Hospital and the academic institution that from the UI that is doing whole genome sequencing for bacteria and contributing to our surveillance network. That's only one place we are doing it in Nigeria, apart from the reference laboratories. That's not good enough. So we must at least scale up, make the genomic sequencing laboratory infrastructure go at least the 6 geopolitical zones, so that other basic laboratories that can offer phenotypic testing can have a particular percentage of phenotypic results that they contribute to a particular lab within the geopolitical zone that can offer genotypic testing. And that's the only way we can begin to have appropriate data on the burden of AMR in Nigeria, and also contribute appropriate data to blasts and traps. So I just wanted to highlight the WHO bacterial priority pathogens, which was updated last year. You could see it is categorized into three. We have the critical group, the high group, and the medium group. Before even the development of this priority pathogen in 2017, many of the physicians and the healthcare professionals don't know that these things are reality. In my hospital where I work at the University of Port Harcourt Teaching Hospital, we are currently doing a study where we have found most of these pathogens, Acinetobacter baumannii, carbapenem resistant, Enterobacterius third generation cephalosporin resistant, Enterobacterius carbapenem resistant. All of these are with us. They are not just WHO reporting. They are in country, and we have these pathogens causing antimicrobial resistance and causing death from antimicrobial resistance, amongst the other ones. So what's the way forward? We've seen the realities and the challenges that we are having. So the Global Action Plan has been said, and Prof talked about it. I don't want to overburden us on that, but that will help me to piggyback with what Nigeria is doing. So the Global Action Plan was actually developed in 2015 from World Health Assembly. And there were about either 5 or 6 strategic objectives. One is to improve awareness, which is what we do during the World AMR Awareness Week. Strengthen knowledge and evidence base through surveillance and research. Reduce incidence of infection through sanitation, hygiene, IPC. Optimize medicines in human and animal health. And develop sustainable investments to local innovations, medicines, diagnostics, vaccines. Next slide. 2 years after, Nigeria developed their own national action plan, what we call now, which lasted from 2017 to 2022. This is a kudos to Nigeria because we joined WHO just 2 years after. It's same objective to increase awareness, build our One Health AMR surveillance system, intensify IPC, based on the tripartite sectors, the environment health, the animal health, and the human health. Promote rational access to antibiotics and stewardship, and invest in R&D. At the elements of this, what were the gaps that were identified from the NAP 1.0? Poor public health awareness and weak coordination of AMR awareness activities, which we are doing this week. There is still poor One Health coordination, the animal health, human health, and environmental health, non-existence of national IPC coordinating body guidelines, and poor budgetary support for IPC activities, lack of stewardship, particularly in the private sector, because the private sector contributes about 60% of what we do in human health. And if there is no stewardship in the private sector, it means that we are not winning the war on AMR. And also the studies on AMR and economic impact were just disjointed and very sparse. So that takes me to the next talk, which is on surveillance. So the surveillance is through the GLASS network, which is a cornerstone for assessing the spread of AMR. It also helps us to inform us where to make interventions, such as IPC interventions, and also to monitor the impact of AMR, whether it's local, national, and the global. So GLASS was also launched. That was the first system to enable us to report our AMR consumption and use data. Just go to the next slide. So if you take a look at this slide, you see that Nigeria, while we have been enrolled in slide, but at the end of 2021, we were only contributing AMR data, which I said is from about 12 laboratories. But we don't have a consumption data, which is so we don't know, we're not contributing on what we are consuming, but we're contributing on the resistance data that we are getting. And that has been a challenge, and we've been working on that as a country. Many of the institutions are beginning to develop consumption data. At the University of Port Harcourt Teaching Hospital, we are also developing our consumption data. And I believe that by the next update of the surveillance network, it will no longer be just 12. University of Port Harcourt Teaching Hospital AMR surveillance network will be included in that, because we are beginning to have data, both AMR data and the consumption data with other institutions. So we may be coming up in the number beyond that 12. So what are the challenges of the surveillance? Talked about it before, but the main thing is what? Funding. We need to fund this because most of the funding is coming from donors. So Nigeria, we need to create a budget for the surveillance. And also we have to continue to train and support our staff to undertake quality AST and surveillance. And of course, physician immunity to stewardship policies. We need to continue to employ the physicians to do more and all of that. So way forward. So what's the way forward for Nigeria? We have to implement the NAP 2.0. We have to strengthen leadership, collaboration, coordination. We must improve our awareness, education. We must strengthen our One Health surveillance network for AMR, IPC, local diagnostic innovations, and optimize the use of antimicrobials across the One Health sector. This is what we have to do as a country. So this is when the NAP 2.0 was approved and was launched by the Federal Ministry of Health. You could see both the three sectors that make up the tripartite sectors were represented there. The former Minister of Health was also there, and then also the DG of NCDC was there with other partners. So it's just to add that Nigeria has also taken a giant leap in the AMR response. We'll be hosting the 5th AMR Ministerial Conference next year in June, where a lot of commitment and reassessments will be done. And that will be happening somewhere in Abuja between 28th to 30th of June. And this is the first time that an African country will be hosting the AMR high-level interministerial conference, showing our commitment to the AMR response. So another thing that we must talk about and we must do as a country is to implement AMS. So these are coordinated interventions that are designed to ensure appropriate use of antimicrobials by selecting the optimal use, optimal drug regimen, dosing, duration, and route. And there is what they call the antimicrobial stewardship, the IPC, and the diagnostic stewardship. They all create a balancing act. If you use the right diagnostics, you should be able to know the right medication to prescribe. And under the context of the right IPC, you should be able to reduce the scourge of AMR. And what are the components of the AMS program? I may not want to bother us much on that, but there are several ways that AMS programs can be. Appropriate use of the lab, infection control, de-escalation, and switch from IV to PO, and then what we call the prospective audit intervention and the formulary restriction. So the formulary restriction and pre-authorization is like a front-end strategy where you restrict prescribing some particular type of antimicrobials for specialists such as clinical microbiology and infectious disease physicians. And then the prospective audit is where you do a kind of a feedback, looking at what you're prescribing and knowing, when to stop. So they have both their advantages and their disadvantages. Then, of course, we should also know about the WHO Aware tool, because you cannot implement AMS without knowing the Aware, the access, the watch, and the reserve medications. Now, this was published in 2021, yet to reflect in Nigerian essential drug list, but soon enough, we'll soon be finishing up. Okay, so next slide, this is the access. You can always prescribe it, and then the watch, you should watch. Reserve should not be prescribed except by consultation of specialists. And this is how the book looks like for anybody who wants to look at it. It's a WHO book, and for the physicians, it can guide you on what to do, how to use it in the context of diagnostic stewardship. Of course, we've talked about all of this. Know your bugs, make your diagnosis, limit your empirical antimicrobial use, know when to de-escalate, identify situations when you need to stop, reduce duration, optimize the PD and PKD dynamics. Okay, so we've talked about many of these. This is a charge to government, increase awareness. Let's build our One Health AMR surveillance system, which we are doing currently as a country. Let's improve access to quality agents, which NAFDAC is trying to do. Let's improve access to better diagnostics, which we are also trying to do as a country. And let's continue to intensify IPC. So to the public, I'll just say we should continue to wash our hands, maintain wash, don't share or use leftover antimicrobials. Let's continue to take our vaccines, particularly in this area of vaccine hesitancy. Vaccination is also key to reducing the scourge of AMR. I've talked about all of this. These are all the mitigation strategies that can be used. Ban on OTC medication have been considered. Maybe as a country, we can look at it. R&D, immunization, hand hygiene. We must continue to develop guidelines. At University of Port Harcourt Teaching Hospital, we are getting to the end of development of our guideline. It will soon come out as a facility. We have our guideline, which we are using to prescribe antimicrobials. We have a committee and a center now that is geared towards antimicrobial resistance. So I will end by saying that we should continue to handle antimicrobials with care, so that it will work for us. Because if there's no action today, there will be no cure tomorrow. Thank you so much for the opportunity to make this presentation.
Wow, thank you so very much, Dr. Chizaram. We really do appreciate your time, your presence, and your support to making this event a huge success. Thank you for the message you've given to us today, and I believe that every one of us on the call, we have been greatly enlightened, and will act on IPC, will act on maintaining hygiene, and will act on taking advantage of the WHO aware classification. Ladies and gentlemen, we are gradually coming to the end of our webinar, and before we close, we are going to jump in straight to the Q&A session, and I would like my colleagues to please spotlight all of the speakers as we share the questions that we have for them. I see Dr. Kome, she has answered a couple of the questions herself by typing, and I think other persons too who have questions too, who asked questions. I believe you must have been, your question has been addressed amicably. So what we are going to do now is just to ask them the few that are left. And the first one that I have on my screen right now is someone is asking, thank you, Dr. Ugonna, for your presentation. There are several challenges associated with metagenomic sequencing of wastewater in Nigeria. How do you think researchers can cope with the cost and maximize the use of AI tools for antimicrobial resistance surveillance? Dr. Ugonna, please.
Okay, thank you for the question. So first and foremost, I must commend Nigerian researchers that they're mostly self-funded, and it takes a lot to do impactful research with your own money. So for researchers to cope with high cost of wastewater metagenomic sequencing, they could collaborate with organizations that have the resources. So for example, NIMA. And so sometimes they provide some subsidized fees to student researchers or to schools when you initiate such collaboration. Also, when it comes to wastewater and metagenomic analysis, you could also do it in batches. You don't have to do large sampling. You could do strategic sampling. So instead of I know that for you to want to publish your work in high impact factor journal, there's maybe a number of samples that you need. So, but the truth is that when it comes to metagenomic sequencing, there's usually enormous data that is generated from that. So even if you sample maybe 2, 3, 4, able to have large amount of data that will be able to give us like a picture of what's happening in a particular community based on the samples that you've collected. So you could start small, and that can also provide us, with information on that community. So collaborating, starting small strategically, one can be able to do that, achieve that.
Thank you very much. That was nice. Thank you. Dr. Kome, you talked about the Sweden as a case study that Nigeria can learn a whole lot of lessons from. And I know you made mention of a lot of lessons that we can learn from Sweden. But Dr. Chizaram made mention of the National Action Plan 2.0. And I was wondering, are there some key indicators of effective implementation of the National Action Plan in Sweden that Nigeria can actually learn and see how we can incorporate or domesticate this in our country to make our own National Action Plan 2.0 very successful? And the reason is because, as Africans, it's not just enough to have an action plan on paper. This action plan, most often than not, are starved of action, and we need to back them with action in order for them to be effective. So I was wondering, what is your thoughts on this?
Okay, thank you. So for the National Action Plan, like you said, I don't think it's developing the National Action Plan that is the issue. I think it's a follow-up. For our former National Action Plan, I think there was a less than 50% for the previous one, NAP1. There was less than 50%.
If you can increase your voice a bit, that'll be fine. We can't hear you very well. Yeah.
Okay, so for the NAP1, there was a less than 50% achievement of it. So the issue is not in the development of the National Action Plan, it's in the actual delivery. So it's these small key points that play a role rather than the big National Action Plan. So if there's a plan to achieve A, B, C, what are the indicators to achieve that? What's the main thing is political will, next is funding. So if there are national action plans and there's no funding to back it up, then that's just going to be a wish in the pipeline. And then like Dr. Chizaram said, look at our population, look at the number of laboratories that have been equipped. For them to be up to standard, it needs money. So the main thing we need in Nigeria, I think, is political will and money. Once those things are in place, then any other thing can take place. We can have more laboratories. Sweden had set up laboratories to diagnose, we're talking of veterinary diseases, not even human diseases. It got to a point where before antibiotics are prescribed for their animals, they had to be diagnosed. We don't even have that capacity for human beings. So for them to have got to that point, you can imagine the amount of laboratories that were set up for them to be working. But we are talking about 10 key laboratories set up nationwide. So for us, it's a matter of money, political will to set up what we need to set up, and then things will run. They will actually run.
Awesome. Thank you. Dr. Chizaram, would you like to lend your view on that, or I should present your question to you directly?
I agree with Prof. It's political will and funding. I mean, we need to fund the NAP 2.0. If you look at that document, it's well written. It's just similar to NAP 1.0, but a bit of improvement. We just need to fund NAP 2.0. That's just a nutshell about it. We need to scale up the labs and do a lot more in AMS. And like she said about subnational, something that sounded like state action plan. I must really commend the Rivers State government, because Rivers State has created IPC AMS committee at a subnational level. So not just about national IPC, but states should also do more. Thank you.
Nice. Thank you very much. Okay, Dr. Chizaram, this one is specifically for you. You talked about the fact that more often than not, when we discuss the issue of antimicrobial resistance, a larger chunk of our focus is on antibiotics. But you know that antibiotics is not just the only pharmaceutical agent under the umbrella of antimicrobials. So why is antibiotics taking the lead in conversation, and why are other pharmaceutical agents like antifungal, antiviral, antiparasitic, antihelmintics, they are not coming to the spotlight as much as antibiotic is doing? And how can we correct this error that people don't ascribe antibiotics to be everything about antimicrobial resistance?
Okay, so thank you so much. So, like I said when I was presenting, antimicrobial resistance occurs across all of the pathogens, whether it's antiparasitic you're using for the parasites. We have malarial falciparum resistance to chloroquine and even artemisinin. But the problem with the antibiotic component, one, the rate at which it's happening, the impact on society, and then also the fact that to be able to deal with it is not just a human health thing. It's not just like, when you take viruses, antivirals are just basically used for human health. But for antibiotics, you use it in animal husbandry. And then if you also notice, the second thing that is coming up now is the antifungal resistance. Those are where they are doing stewardship program. There's only two stewardship programs: antibiotic stewardship and antifungal stewardship. So why stewardship? So that you can use it as at when due. And a very good example was what Prof provided. Somebody has a flu, see it every day, and you have to prescribe antibiotics to treat viruses, and that doesn't work. So you've just exposed the person to antibiotics.
All right. Thank you very much, our resource persons. Now, this is the last question, and I would like your response to it will be your closing remark. And the question is, given your profession and what your expertise and your experience so far, what is one key thing that countries all over the world should do at the moment in order for us to secure our collective future? From your expertise and your experience and the work that you do at the moment, what is that one thing that you think countries all over the world should do in order for us to secure our collective future? Dr. Komen, I will start with you, please.
Okay, one thing that countries should do, or one thing I think that countries can do, one is to work together. International collaboration cannot be underemphasized. Like Dr. Chizaram said, the world is a global village. An issue one place is going to take less than 48 hours to get to the next place. So every country needs to work together. So you have scenarios already where you have the high income countries helping the lower middle income countries. So there has to be this synergy for us to secure our future.
Thank you very much. Dr. Ugonna, what's your take on this?
Thank you very much. So for me, I would say we have to build integrated real-time surveillance system that would combine clinical, environmental, and genomic data. So, and also we'll have to make AI a core part of how these systems can help us dictate emerging threats. And
Nice.
yeah, the single action to improve antimicrobial, dictation would. So we need to be prepared, and to be prepared, this is something we have to do in collaboration, integration, and therefore prepare for future pandemic, because saw what COVID-19 did. So we have to be ready.
All right. Thank you so much. Dr. Chizaram, your closing thought on that, and then we draw the curtain.
Okay, so I'll just align myself with Professor Kome with the fact that we must continue to ensure global solidarity. We are in an era of increasing, multilateralism that wouldn't take us anywhere. And I'll provide an example. The Fleming Fund, which have been supporting Nigeria, drive our AMR. I'm getting some information that the UK is cutting a lot of their aids. Now, it's simple to do that, but if one person is not safe somewhere, every other person, the other side is not safe. So a global solidarity framework for AMR should be sustained.
Awesome. Ladies and gentlemen, thank you so very much for joining us, and a bunch of thanks to all of our speakers and resource persons for their time and effort presenting and sharing with us today on the subject matter of antimicrobial resistance. Yeah, we'd also love to draw your attention to this slide on your screen. You are free to act on it and lend your support so that the Global Health Network can continue to bring wonderful sessions like this to you free of charge, so that we all can learn together, we all can collaborate together, we all can network and help ourselves to win the fight against antimicrobial resistance. I really want to thank everyone for making our time to be here. It's been wonderful. We have been richly blessed and enlightened by the presentations of our speakers, particularly Dr. Professor Kome Otukunefo, Dr. Chizaram, and Dr. Ugonna Morikwe. On behalf of every one of us at the Global Health Network in Oxford and the Global Health Network Nigeria, really, really want to appreciate you for joining us. And up until we come your way again, we'll always continue to bring the latest information on research, enabling research everywhere, every time, for everyone. The recordings of this session will be available on the Antimicrobial Resistance Knowledge Hub of the Global Health Network, and also on the Global Health Network Nigeria Country Center page. You are free to check on us at your leisure and take advantage of wonderful resources that will help you in advancing your research. Thank you so very much for joining us, and do have a wonderful day.